Vegas. So great to hear and to have you, Don. It's so great to have you here. Please do introduce yourself, please.
Yeah. Hi, folks. Don Rucker. I'm the Chief Strategy Officer at upHealth. Some of you may know me from my days as National Coordinator at ONC in Trump 1. And folks, even before that, may have known me as the Chief Medical Officer at Siemens and ER doc, and involved one of the principals in the very first in the world Windows electronic medical record, the first people ever to use Dragon in healthcare.
Oh, wow.
So I've been around for a while
That's
in
great.
the healthcare IT
That's
space.
good. Well, you've seen a lot of transformation happen.
So yeah.
That's great.
Yeah.
Well, tell us a little bit more about the role you're in today and the company that you're helping to lead.
So upHealth is it really is a company that leverages the power of FHIR data.
Right.
That's really what it is. And part of that are the CMS FHIR APIs that are trying to make healthcare more fluid and enable all of these workflows that at HIMSS, where we're sitting, is an entire show floor full of things. I think the interesting part from a business point of view is we believe there's a fundamental underlying transformation in the way care is allocated and then the way care is paid, since those two things are kissing cousins.
Right, absolutely. So you've seen a tremendous amount of transformation happen, both as a person who led transformation on the federal side, and now on the vendor side. Talk about that journey and what have been some of those milestones and things that you've seen that have really helped to transform the industry, and where do you think we still need to go?
Yeah. Well, I think sort of big picture, and of course, we're in that transition from planets here, so big picture might be the might be the solar system view.
Right.
If you look broadly, healthcare, certainly from the feds, was anybody who provided a service was going to get paid from probably 1965 to around the year 2000. And then around 2000, and this has been building up, we started on this search for value and quality. And we've all been to 1,000 talks on the search for value and quality measures and all of this stuff. But the picture was, we went from pre-year 2000, what was called any willing provider. So if I have a license and I want to bill the federal government, you, the taxpayer, have to pay me, because unless I'm doing something blatantly fraudulent, it's patient care and you have to pay. Circa 2000, people said, wait a minute, we're paying the same amount for somebody who's a bozo, to use a non-clinical term, as we are for, the great care that I would provide. All doctors have a belief that my patients are sick, etc. So we'll go there. Well, turns out that didn't really solve much, because doctors were still billing more, doing more. And so in the last couple of years, it has shifted to a third phase. I don't know, third rock from the moon or whatever, how you guys want it. But it has shifted to, and of course this has to be a very subtle shift, not a public shift, because that doesn't really work, to payers allocating care. Right? You providers, you're just going to do your thing, and we're going to spend more and more and more. So the payers are now delegated sub rosa by the government to allocate care. So what on earth does that look like? What does that mean? Well, first and foremost, it's Medicare Advantage. And then the other big one is Medicaid, which now in most states is managed Medicaid. Most states have delegated that in capitated plans. If you have a capitated plan, it's not like there's no moral hazard, right? The moral hazard in fee-for-service was, we're going to do more. The moral hazard in capitation is, we're going to do less. We're going to do.
But is it more on the care side and more on the health side?
Well, Great question. We're going to get to that.
Okay.
We're going to get to that. That's
Okay.
absolute heart of the conundrum.
Absolutely.
That's the absolute heart of the conundrum. The hope is that it is less on the cost side and better on the care side.
Right.
But other than that, how was the play? That type of thing. Right. And the problem has been the moral hazard's still there. We're all people. We all respond to incentives.
Sure. And
so what's happened is we've had to come up with these very complex constructs on allocating care. Let's stick to Medicare Advantage.
Sure.
That's what OneUp service is, as well as a lot of Medicaid. But let's stick to that. And so what do those complex constructs look like? Well, you may not think of them as the feds and the taxpayers controlling the allocation of care. But if you think about hierarchical condition system, the HCC classification to get paid, if you think about narrow, or skinny network design for MA, if you think about prior auth, and maybe most importantly, prior auth is probably the noisiest one from a public point of view.
Sure.
But the one that has the biggest transcended dollar impact are star ratings, right? These are all ways that MA plans manage care or get paid for care. And that brings us to, I think, the big transition that's very interesting and that we're really feel at OneUp is sort of the thing. And that transition is, up until now, we've basically paid on claims data, right? So I'm a doc, I write something in the chart, some coder codes it, submits a bunch of CPT codes, submits a diagnosis code, and then sends it to the clearinghouse and sends it to the payer claims engine, and then, eventually whatever money goes to the providers. And we have tried on that very narrow thread of claims data and diagnosis data, so IC10 data these days, to have the entire care allocation system.
Right.
It's like you building a skyscraper on twigs and mud.
Right.
And that, in general, doesn't work. Maybe in San Francisco with Millennium Tower.
Right.
They tried it, but in general, it doesn't really work.
Sure.
You can Google Millennium Tower if the analogy is too much.
No, that's great.
There, of course, was actually the cheapness of trying to use pre-tensioned or post-tensioned concrete instead of structural steel.
Sure.
And that drilling the extra 60 feet to bedrock.
Right.
And then the whole thing is, in stages of kaput.
Exactly.
In healthcare, our kaput is the information theoretic path of claims and clinical data is not enough to support rational allocation of care. It's not enough to do prevention.
Why is it? Because it's post-care?
No, because it's so thin a thread of information. Right? We got a lot of cells. We have a lot of biology. We have a lot of disease.
Trillion.
Yeah, exactly. Yeah, I heard it was 59, but it was 60.
We'll round up.
I'm a little heavier, so I got an extra trillion. I'm sure, something like that. But kidding aside, there's a lot of complexity, right? And there's just not enough information from an information theory point of view. You're CIO, you've lived information theory. And so we believe that the solutions to many of these things are truly going to require what these FHIR APIs are now allowing for the first time, which is the sharing, appropriate sharing. I'm not talking about TEFCA or some data stealing kind of activity. Maybe that's not 100% fair, only 99% fair.
Well, I want to come back to that. Yeah, that's an interesting comment.
That's a separate side note. But payers and providers who have a right under HIPAA, a true legal right, and frankly, public expectation, that data, payers and providers have to have a much richer dialogue infused by all of the FHIR data fields.
Sure.
So we're talking the U.S. core data for interoperability. So meds, problem lists, notes, allergies, maybe care plans. because that's the only rational way to do stuff. You can't just run every single procedure, no matter what, through prior auth.
Right.
You have to tamp down the gaming. You have to be smart about network design. And certainly for quality measurement, wouldn't we want more clinical data rather than the, I'm thinking what a politically correct description of our current quality measurement system would be. Maybe tortuous comes to mind, right?
Right.
Where we, have chart chases
Sure.
and primary source verification
Exactly.
and all kinds of anti-modern patterns of behavior and software.
Right.
So all of that world nets out that care allocation is going to be with much richer sets of clinical data,
Right.
not just CPT and ICD-10. It's very exciting. That, of course, allows AI. It allows all kinds of modern things. It gives us a fighting chance to actually take far better care of patients. Right now, as everyone knows, it's a reactive healthcare system. You come, you get a symptom, you come to the office, whatever, do whatever. I'm an ER doc, so,
Sure.
maybe you wait a little longer than you see me. But, boy, in a world where we have chronic disease as their number one problem, Bobby Kennedy Jr. and Maha,
Right.
like, why on earth are we waiting till you're sick to prevent stuff that are really
Sure.
dynamic lifestyle choices?
Absolutely.
And that can be modulated
Right.
by new APIs like, the
Right.
stuff that we do.
And that's what I was talking about, the health side. They're
Yeah,
doubling down
so
on that.
it's really that
Yeah.
total communication
Yeah.
prevention API. We should not be
Right.
different in healthcare than flying here on, pick your airline.
Right.
I flew here on American. They knew whether the flight was on time. They knew my seat. I could change my seat. I could see my bill. I could see the delay, or
Sure.
I think it was actually early, to the minute, 2,000 miles away.
Right.
Geez, why do we not have that kind of data flow in healthcare? So it is available. That's where you're going to put AI on it. I do some stuff with a company called GenHealth.ai
Right.
that has incredible algorithms to predict care and triage care. But again, they require vast amounts of data. Today, those folks are literally, the founder, Ricky Sahu, was telling me he's had to figure out how to parse faxes.
Interesting. Yeah.
Why would an
fax machine?
why would an AI company in 2025 be relegated to being forced to parse faxes?
Right.
So this broad world of APIs, which CMS and ONC,
Sure.
at least under the Cures Act, have enabled, really, and FHIR and the work that HL7 have done over the last 15 years is enabling a totally different way of looking at healthcare.
Sure.
And by golly, we should do it.
No, absolutely. Absolutely.
So Don, I feel like we could go over.
Yeah. Are we
No. All good topics.
It's Bat Channel
No,
time.
no.
Didn't let me watch Batman in the 60s
Right.
because it said it was too dangerous for us. So
No, these are all great topics.
Yeah.
Yeah.
Like
A wealth of knowledge.
Strategist,
Oh,
legend. I mean, you.
Oh my
just
God.
unpeeled
I have so many
the
questions
whole
for you.
regulatory,
Yes.
Put it back together. Is there anything? I feel like we could do a 12-part series
Yes.
for today at HIM.
Yeah.
Lessons for going forward. With
Absolutely.
This, and you even said the Maha. You've been the first one that we've heard that's mentioned.
Oh,
Give us some
I
hope.
saw that on the
Right.
news.
Yeah.
Just kidding. But kidding aside,
Yeah.
it's really the enablement of computable data.
Absolutely.
Right? I mean, what's the difference between FHIR and the stuff we've done in the past? In the past, we have not had broadly computable data.
Sure.
We may have had, lab feeds, HL7V2, imaging, DICOM,
Sure.
PACS,
Right.
highly networked, very impressive from a tech point of view. I was privileged to be chief medical officer at Siemens that, built a lot of the CT
Right.
and MRs. Excuse me. But we haven't been able to compute on the core clinical data.
Right.
And now, with FHIR and these economic pressures, I think we're at the point where we're going to be able and required to compute on clinical data and rich patterns of our health as human beings.
Sure.
And that's, I think, a real
Right.
win. And I think HIMSS, HIMSS 2026, 27,
Right.
28, whatever, that realization is going to become clearer. I don't think it's fully clear today because I think sometimes, people are still, well, fire, what's that? How do you spell it?
Right.
I don't feel like doing no APIs, whatever.
Right.
And of course you have a number of legacy operations, mostly represented in Tefka, who have a long track record of not wanting choice for consumers, preventing competition, preventing digital. So, it's had impediments that in the rest of the economy, digital doesn't have.
Absolutely.
Just because of our payment system is designed to prevent interoperability.
Exactly.
Literally, right? The whole business of maybe your former employer, not to mention any names, is capture high margin procedures and make sure no patients are leaking anywhere else.
That's right.
That's
our model.
And then the federal government has to sort of piecewise put in little snippets of, oh, you should share data, shame on you.
Right.
So we have a thing where the federal government has to do a forcing function.
Right.
Unfortunate, if consumers were truly in charge, this trade show probably wouldn't exist.
Yeah, we've solved the problem long ago.
This would have been automatic and low cost.
Yeah.
Otherwise, because of the payment system, it's Byzantine and generates vast amounts of heat.
Exactly.
Yeah.
Man, we got to have him back on like 5 more times.
I'll ask my mother.
It's not past your bedtime.
That's right. You are a wealth of knowledge. So,
thanks.
So, if someone wanted to find out more about what you're doing with your new, this new venture you're in.
oneup.health.
Yeah,
oneup.health or
the number one, right?
Yeah, the number one, up.health.
Right.
And I may have said some things that ended up on YouTube or in Google.
Yeah. Okay.
I can't say that I've been totally anonymous.
Good, and don't be disruptive.
So
absolutely.
You can get the
you're our kind of people.
You can get the potpourri of beliefs, hopes, dreams, and outrageous statements.
Absolutely. Well, there's a reason his podcast is named that, and mine is called Straight Outta Health IT. So
cool.
Yeah. So we
is
both
this a twofer?
It's a twofer.
Oh, awesome.
Yeah.
Oh, awesome.
Yeah.
Didn't know that was legal, but
well, that's why we're disruptive.
Alrighty. Thanks.
Thank you.